Hello, and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Deborah Foreman, the Educational Programs Coordinator for MS Focus, and I'm joined by Dr. Augusto Miravalle, MD, who will be talking to us today about comprehensive care in MS beyond preventing relapses. After a presentation from Dr. Miravalle, we'll open it up to your questions and comments. Now I'm delighted to introduce our speaker. Dr. Miravalle is an associate professor of clinical neurology at the University of Colorado. He provides care to patients at Advanced Neurology of Colorado. Dr. Miravalle is a board certified neurologist who subspecializes in multiple sclerosis. Dr. Miravalle received his medical degree from the University of La Plata, Argentina. He completed his neurology residency training at Loyola University, Chicago, where he served as chief resident of education. He subsequently completed a neuroimmunology fellowship at Harvard University in Boston and a fellowship in medical education at the University of Rochester, New York. Dr. Miravalle is the recipient of the 2012 American Neurological Association Medical Education Fellowship Award, 2015 American Academy of Neurology Research and Education Award, and 2015 American Board of Psychiatry and Neurology Faculty Education Innovation Award. Dr. Miravalle has been involved in both clinical and science-based research in the field of multiple sclerosis and neuroimmunology. He is a member of many professional societies and advisory boards. He is frequently invited as speaker at national and international meetings. He has published numerous scientific articles and serves as a consultant to various scientific organizations. We're very pleased to have him join us today and to present this wonderful topic. Dr. Miravalle, thank you so much for being here with us today, and I'm going to turn it over to you.
Thank you, Deborah, and thank you to MS Foundation for putting together these amazing programs and helping us to reach out to our patients in ways that hopefully we can meaningfully impact their understanding of multiple sclerosis. So for today's webinar, we decided to approach the topic of MS from a slightly different angle. We frequently talk about clinical outcomes in multiple sclerosis, which perhaps most of you are familiar, preventing relapses, perhaps MRI outcomes and lesions and atrophy. And those are very important outcomes, and certainly those are things that we often discuss with our patients in the clinic. However, most patients, when you ask what are the most critical factors in their disease journey that actually affects their quality of life, most of the times are things that we often don't discuss in the clinic. And that's why I thought to focus today's presentation on the so-called invisible symptoms of MS. And those are the ones that actually also require to have a multidisciplinary approach, as often patients require to have multiple providers to assist in the care. So today we're going to review the definition of factors that influence quality of life in MS patients. We will discuss fatigue in multiple sclerosis as a model of multidisciplinary care. And of course, we will present a model that tries to exemplify how we can approach these very complex topics from a patient-centered standpoint. So let's define what is quality of life. And the WHO defines quality of life as an individual's perception of life in the context of culture, value systems that they live in, as well as in relations to their goal, expectations, standards, and concerns. When you look at the health-related quality of life, which is the second bullet, is something that is similar to what was defined by the WHO, but actually has to do directly with individuals' health status. And it's going to be multidimensional, and it's going to include things like physical, occupational function, emotional status, like depression, anxiety, for example, social interaction, and somatic sensations. How about quality of life in multiple sclerosis? So there have been many studies trying to understand what drives quality of life, or what influences quality of life to the greatest extent in MS. And by far, the two most popular areas are fatigue and level of disability. So here you have other factors that influence quality of life. And you can see that there are factors that pertains to patients themselves, factors that actually are related to the environment, as well as factors that are related to the disease itself. And you can see that culture, society, for example, economy, financial aspects, public services, availability of resources, of course, will affect quality of life. Mental health, attitudes, and beliefs. I often tell my patients, attitude is half the battle. And no matter what you're going through, if you have a relapse or an issue with MS, of course, there are many things we can do, but having a positive attitude, having an attitude of empowerment, being able to take the lead in your own health is going to help you not only go through that difficult time in a much pleasant way, but also give you some clarity of mind that will allow you to actually take the best advantage of the tools that you have available. And then there are other factors like leisure and social life, level of education, learning, relationships, and work. Those are factors that will certainly influence your quality of life. So this was a study particularly done in MS patients that looked at patients with and without depression and patients with and without fatigue. And they measure quality of life in all four groups. So you have a group that is represented in the light gray, that is MS patients without fatigue. In the darker gray, we have MS patients without depression. In the white with the black dots, you have MS patients with fatigue. And in the white with the lines, you have MS patients with depression. And you can see that any domain of quality of life that you can think of, anywhere from the physical domain, physical function, health perception, fatigue, pain, sexual function, and social function, all of these domains of quality of life will be significantly lower if patients have either fatigue or depression. So we know that these two factors will play a critical role in affecting, independent of anything else, independent of disability, independent of brain lesions, of medications for MS. If patients have these two factors, their quality of life will not be optimal. So let's start with one of the two, and I will make an effort to explain that from a clinical standpoint, but also to try to give you some practical tips that you can take today and hopefully improve fatigue if you have or if you're suffering from fatigue. We know that it's common. Up to 90% of patients with multiple sclerosis will experience fatigue at some point in their life. MS-related fatigue can occur at all stages of the disease, anywhere from the newly diagnosed patients to patients that had MS for 40 plus years. So truly does not depend on where you are in your journey. Fatigue is different from being tired. Fatigue is going to hamper daily activities. It's going to be lessened by cold temperatures. It might be triggered by stress or hot temperatures. We also know that fatigue is variable. 50% or more of MS patients will fluctuate between a fatigue and a non-fatigue state, whereas 30% of MS patients have what is called a persistent state of fatigue. No matter what they do, how many hours they sleep, no matter what they eat or how much exercise they do, they will have fatigue. And approximately 10 to 15% of patients never had fatigue. And we are trying to understand what are those factors that determine that difference. So fatigue is being defined as a subjective lack of physical or mental energy. We know that primary fatigue is a fatigue that is directly related to the disease process itself, where secondary fatigue is that fatigue state that is consequence of other factors, including lack of deconditioning, depression, as well as medication side effects. You can even subdivide fatigue into these two states, right? So one called the fatigue trait, which is this global status of a patient that's not changed over time, is this persistent fatigue, the situation in which patients in the morning, even after sleeping 8 hours and resting well, they are tired. And no matter what they do, they're going to be tired. This fatigue apparently has little effect on other external factors, but it does respond very well to cognitive behavioral therapies, to processes including interoception and metacognition that many neuropsychologists and occupational therapists are familiar with. And those are things that actually often I recommend considering if you feel that that's where you belong in that fatigue trait. That is independent of anything else, perhaps work with an occupational therapist and a neuropsychologist to try to see if these techniques may help you. And then, of course, you have the fluctuating state of fatigue, which it's going to be influenced by physiological and biochemical processes, by stress, by temperature, by medication side effect, by other metabolic disorders. So how about the root cause analysis of fatigue? So what causes fatigue in MS? Well, as you can imagine, it's not simple, and certainly it's not one factor. And that's why it's so difficult to address fatigue. And that's why we need a multidisciplinary comprehensive approach, because we truly need multiple providers to not only diagnose what is the root cause analysis of fatigue, but also what can we do to help these patients with fatigue. So of course, we know that inflammation, which is the hallmark process in multiple sclerosis, it's going to affect fatigue. We know that there are structural damages in the brain in both compartments, the white matter and the gray matter of the brain, that has direct effect on fatigue. We also start to understand what happens in those networks in the brain, right? So we know that the brain, what forms the brain is a bunch of cells. We have over 10 trillion neurons in the brain, which are the primary cells, but we have also other types of cells like microglial cells, astrocytes. Those are the support cells, the cells that help to clean up any debris that comes out of like the use in the brain, right? So we have multiple types of cells, but also we have networks, we have connections, and those pathways actually, whenever they are affected, it's going to have a direct impact on fatigue levels. We know that hormones and neurotransmitters are going to affect fatigue, and certainly secondary aspects, including spasticity, sleep, and medication side effects. So let's start with one of these factors, structural damage. As a consequence of inflammation in the brain, as we all know, there are scars that get created in the brain, as the name multiple sclerosis comes from the Latin name of multiple scars. And those are the scars that we see in the brain of our MS patients when we do MRIs. But also beyond these lesions, the brain gets affected in the spinal cord as well with the process of atrophy, as well as lesions in the gray matter. So this is just to show you something that perhaps you're familiar with, which how an MRI looks like. You have these white dots in the brain, and we look at the size, the appearance, the location to try to make not only the diagnosis, but also understand how things are going. And as you can see in the bottom of the slide, you have 3 different patients there. And the EDSS is a number that we use that reflects the level of disability. The higher the number, the higher the disability of the patient. And you can see that these 3 patients have different levels of disability with different duration of the disease and clearly different amount of lesions. So these 3 factors don't necessarily go hand in hand, right? So the number of lesions perhaps is not as important as the location. So as you can see in the example in C, that patient's EDSS is the highest, meaning higher disability, yet that patient had MS for 7 years, which is the lowest duration in these 3 cases, right? And if you look at the number of lesions, that patient doesn't have that many lesions. So how do you explain that? Well, probably it's explained by other factors. Perhaps this patient had lesions in the spinal cord that we know that brings more chances of disability, but also this patient had perhaps more brain atrophy or other factors that influence that degree of disability. And the same is true with fatigue. So when you start looking at does the number of lesions, for example, correlate with fatigue levels? The answer is no. As a matter of fact, the so-called benign MS, which is a term that is highly controversial, but some patients do have a very benign course of the disease. Those patients have as much fatigue as patients with so-called no benign MS. Fatigue is also known as being a prodrome for MS. So patients often have fatigue prior to the first relapse, sometimes 4 to 5 years before the diagnosis. We know that fatigue comes from the brain. There is what's called a neurogenic component of fatigue. So it's not that you're making that up. It's not that you're tired. That's a real problem that comes directly from the brain. As I mentioned before, the level of fatigue or the presence of fatigue is independent from other factors, including physical disability, the number of lesions, or any other metrics that we can measure on the MRIs. So in terms of location of lesions, I often get a question in the clinic. My patients ask me, well, can those lesions explain my symptoms? And sometimes yes, when, if we find lesions that are, let's say, in the optic nerve or in the spinal cord, we can actually localize these lesions and assign some symptoms to it. But for the most part, it's hard to, particularly in the upper part of the brain. In terms of fatigue, certain locations of the brain have been linked to fatigue, including lesions in the frontal, temporal, and parietal areas of the brain. There is no good correlation with enhancement. We do know that in terms of brain volume, patients with reversible fatigue and sustained fatigue have lower brain volumes than patients that never had fatigue. So brain atrophy is a factor that perhaps is linked to that. In terms of location of the atrophy, well, perhaps that frontal part of the brain, the one that is on the front of your brain, has the highest level of correlation. So that concludes that portion of the talk. That is like, what about that structural damage in the brain and fatigue? Can we correlate? And the answer is yes, to some degree. And that's why in one of the roles of this multidisciplinary management of MS and fatigue, for example, is to try to prevent lesions, to try to prevent atrophy, to try to prevent a disability accumulation. As we mentioned before, inflammation in general will be linked to fatigue. And that's why another goal for the management of MS patients is to decrease inflammation. And now we have multiple therapies that are approved, over 25 disease-modifying therapies that will, for the most part, affect inflammation. So this is just to refresh your memory. I know that you've seen this before, but this is the typical graph that we draw in the clinic to explain to patients early on in the disease process. After you've been diagnosed with MS, there is this very aggressive amount of inflammation that happens. And that inflammation is the entrance of these immune cells to the brain. They, as you can see in A in the bottom of the slide, that depicts a pathological sample of a brain with a blood vessel in the middle, and you see those blue dots. Those are the immune cells. Those are the cells getting to the brain, and they're trying to go after an area with myelin. In B, you can see that white dot in the center of the slide. Well, that's an area of demyelination. And in C, after that immune cell interaction with the brain causes demyelination, these axons, which are these black cords or wires that you can see in the picture C, they will break in the middle. And that's when you have axonal disruption. And besides demyelination, you have axonal loss. If you do an MRI, not only you see those white dots, but also you see those dark lesions. We call them black holes. So black holes in an MRI, as you all remember from previous talks means that these lesions are deeper, also affecting the axons. So that inflammatory phase gets less and less aggressive as we age. And that is from a process known as immune senescence, right? As we get older, our immune system also gets older. And that's why you see that that inflammatory phase decreases over time. So one practical point, learning point from this slide is I mentioned that we have over 25 anti-inflammatory therapies, and these drugs work by preventing inflammation. So you're going to understand by looking at this graph that the highest chances of high meaningful effect on inflammation is going to happen early on in the process of the disease. And that's why we all advocate for early use of highly effective therapies to try to stop inflammation from the beginning. As disease progresses over time, you have a second phase that we call degeneration. And that phase is usually driven by brain atrophy, is usually the one that brings things like fatigue, even though fatigue could be present at any point. Usually you have more that this fatigue state and trait at the end of this phase. And this is things like usually patients complain more of ambulation problems and cognitive decline and so on and so forth. So this is a cartoon that I always like just because it gives me an opportunity to show how these cells get to the brain. So in the top of the slide, you see a blood vessel, and these immune cells called the lymphocytes, and the T cells and the B cells get through that blood-brain barrier inside the brain, trying to find an axon or a brain cell that has myelin, and will try to destroy that because they got confused, they got the wrong signal, and they're trying to go after that. So that's, if you do an MRI at that point, you're going to see a lesion, and because there is enhancement, there is a disruption of the blood-brain barrier, that lesion is going to enhance. Another question that often patients have is, what type of MS do I have? Do I have relapsing remitting MS? Do I have secondary progressive or primary progressive? And that's a distinction that we make clinically. But in terms of fatigue, fatigue levels are not associated with the phenotype. Whether you have relapsing MS or progressive MS, fatigue is being linked to both types of MS, and it does not depend on the type of MS that you have. However, fatigue is associated with older age. The older you are, the more likely you will get fatigue. That's true with or without MS. It's also associated with lower levels of education. And the good news is that it's never too late, right? So education doesn't stop in college. And no matter how old you are, you can still learn and you can still try to improve your education level. And there is a link between that and levels of fatigue as well as depression. In terms of medications that are used for MS, can they help with fatigue? There have been several studies, and the answer is we don't know. Some studies show some benefits, some studies didn't show a benefit. Most of the time when there was a benefit, we learned that it's because of these drugs affecting, as I mentioned before, that anti-inflammatory properties that they have. So this is what I was mentioning before, more reasons to start the medications early as possible, because if we stop inflammation as early as the diagnosis of MS, we have the higher or the highest chances of affecting long-term outcomes. So two words in terms of these maladaptive network connections in the brain that affects fatigue and many other outcomes in MS. We know that in terms of networks in the brain, there are many affected with fatigue, but those actually that go to the frontal lobes are the ones that have been consistently found to have an effect on fatigue. And you can see here a cartoon that shows these thalamic cortical connections. The thalamus is that center of the brain that is going to get all the information from the external world, the sensations, the proprioception, pain, touch. All these sensations are going to get to the thalamus, and from the thalamus they're going to go to the brain. So patients who have, for example, numbness or decreased sensation, decreased proprioception, they're going to have less stimulation to these pathways, and that could eventually be linked to higher levels of fatigue. And that's why one of the things we always recommend is do physical therapy, continue to stimulate these pathways. The more you use them, the better them get, and the less fatigues you get. Okay, so that sensory input to the brain is very important. But also the function of the brain, one of the many functions, but one is moving, that motor function of the brain, that you can see here also in the lower green arrow is the one that is allowing you to coordinate movement. If there is any structural damage in those networks, patients are also going to have fatigue. Other possible reasons, a big one is sleep disorders. And for many decades, MS neurologists, we've been neglecting to think about sleep up until recently that we are learning. And the more we learn, the more we emphasize the importance of sleep studies in MS, is that many of the problems that our MS patients have could be linked to sleep disorders, anywhere from obstructive sleep apnea, central sleep apnea, movements of sleep, interruptions of sleep for secondary causes like bladder issues or pain or spasticity. So sleep disorders are a big one. And if you've been trying to fix your fatigue and you can't find the answer, if you didn't have a sleep study, maybe talk to your doctor about it, because that might be where the answer is. And of course, depression, it's a big one. So going back to why do some patients have fatigue and some patients don't have fatigue? What makes the difference? And why some patients have 20 lesions in the brain and they're perfectly fine, and why some patients have 2 lesions and they have a lot of disability? Well, there are many ways to explain that difference, but one way is through the concept of neurological reserve. And that means that the brain as an organ has 2 compartments, if you wish. One is the functional brain that you use to do activities of daily living, to drive, to walk, to go to work, to socialize. And then you have the part of the brain that is your reserve. And that reserve serves a purpose to be there to compensate for future activities, to compensate for pathological states. Let's say that tomorrow, you had a bad day and you have a lot of stress and you didn't sleep well. Well, probably you're going to function using your reserve, right? So that reserve is kind of like your savings accounts in the bank. And you can subdivide brain reserve into 2 types. The brain reserve that is called the passive brain reserve, that's things like the size of your brain, the amount of synapses, the amount of connections you have. That's something you were born with. It's genetically determined, and it's kind of like your hardware in the brain. That if you compare a brain to a computer, that will be the size of the monitor, the amount of memory in the computer, and so on and so forth. So that's your passive brain reserve. Then you have your active brain reserve. That's the one that you can change. That's the one that you can train your brain to be better. That's your software. That's the one that you can upload different programs and update them and bring more efficiency to your computer. And this is independent of your genes. This is independent of gender, of age, or anything else. This is something you can work today on improving your brain reserve. And how do you do that? Well, that's through many things, and leisure activities, for example, educational attainment, learning. What you're doing today, you're learning something. So you're improving your passive brain reserve by physical activity, for example, by exercise, and so on and so forth. So these 2 types of brain reserve are constantly working with each other to try to compensate for issues that perhaps MS brought to your life. So this is another way to look at the natural history of MS. And as we see over time, as the disease progresses and we age, one of the things that happen is that our brain will shrink. And that happens as part of normal aging. That's called brain atrophy. And you can see in that blue line in the center of the slide, that's the expected rate of brain atrophy. That is usually approximately 0.2 to 0.4% per year of atrophy as we age. MS patients without treatment have an accelerated rate of brain atrophy. And you can see that green line on the bottom of the slide that tries to depict the brain atrophy that we see in MS. So how can we prevent that? Well, many ways, but certainly with medications for MS, those anti-inflammatory therapies have an effect on brain atrophy. But also, as I mentioned before, the more you use your brain, the better it gets, and the more you prevent further atrophy. So can we measure this? Can we actually see how much atrophy and how these connections in the brain are working in an MS patient? The answer is yes. So we certainly can look at atrophy on conventional MRIs, but now we can also start looking at these networks and activation of the networks in the brain by looking at different types of functional MRI. And you can see in this slide that the row of A, B, and C, those are patients with multiple sclerosis with fatigue. And in the row of D, E, and F, those are patients with multiple sclerosis without fatigue. And these two patients are doing the same task. And you can tell me that on the top row, A, B, and C, there is more cortical activation. You see more of that red, orange, and yellow compared to the D, E, and F. So what that tells you is that these patients with fatigue, in order to do the exact same function, they have to use more brain. And by using more brain, they're constantly utilizing that brain reserve. And that's one of the reasons why they result in higher levels of fatigue. The good news is that the same study was done in people with and without medications for MS, as well as with and without physical and cognitive therapy. And as you can see in the baseline, these patients were using a lot of brain, meaning that they were compensating for to do the same functions by using more of that brain reserve. But after 1 and 2 sessions of cognitive behavioral therapy, after starting medications for their MS, they managed to reduce the amount of cortical activation to almost near baseline control levels of people without MS. So you can modulate this. The brain is very plastic. So even if you are in the state of baseline levels, that you're using a lot of brain, it's not efficient, by training your brain, by using anti-inflammatory therapies, you can actually improve the efficiency of those pathways. How am I doing in time here? Let me check because I tend to run a little bit over, so I think I'm good. So moving on to another example of factors that affect your quality of life that require a comprehensive multidisciplinary approach is depression. And depression is under-recognized in MS. There are certain groups of MS patients that is even more under-recognized. And it will have a direct effect on negatively affecting fatigue levels. Sleep disorders, as I mentioned before, neurogenic bladder. This is not only because of the potential inflammatory association with urinary tract infections, but also if you have to wake up 3 times at night to use the restroom, you're going to have interruption of your sleep and you're going to be fatigued. So sometimes the way to fix fatigue is through the bladder. Pain, spasticity for similar reasons, and as well as medication side effects. So depression is more than just being sad. We know that depression also includes things like loss of pleasure or interest in activities, sleep problems, fatigue, psychomotor retardation, reduced appetite. Irritability is a big one. I do find that patients often tell me, I'm not sad, but I'm angry. And I can't stand my coworkers and I can't stand my spouse. And that could be a sign of depression, right? It's not just being sad. Some people manifest depression through other type of symptoms. We also know that it's very common in MS, of course, and there is an annual prevalence of 50%, for example, in certain studies. And there are seasonal variations. Of course, it's affected by weather, by sun exposure, by vitamin D levels. So there are many factors that actually will affect fatigue. There are certain locations of the brain that again has been linked to higher levels of fatigue, including the medial, left inferior frontal and temporal regions. So anxiety, similarly to fatigue, is seen in many patients with MS. but also the partners, right? So we have to take care of our spouses too. And very often, MS patients and their spouses, they both suffer from fatigue and depression. And another consequence of these two is cognitive impairment. And we know that processing speed, meaning the ability to process information in a given unit of time, that processing speed gets affected by depression and fatigue. We do recommend medications, but also I recommend counseling, psychotherapy, exercise, phototherapy. So it's not just a medication that helps with depression, but we often recommend multiple interventions, again, going back to this multidisciplinary approach. Similar to fatigue, we have other secondary causes that will affect depression, like thyroid disorders, medication side effects, as well as vitamin D deficiency, anemia, iron deficiency, and so on and so forth. So how about interventions? What can we do from the standpoint of healthcare system as providers to help our patients? So this graph shows you the amount of research studies that has been done to address fatigue from a multidisciplinary standpoint. So the color code shows the studies that were successful versus no, but also the size of these bubbles represent the number of studies. And people have looked at things like pharmacologic interventions, exercise, behavioral education, combination, and so on and so forth. And here is just a snapshot of the results. You can see in green those interventions that were considered effective. In yellow, those interventions that the evidence was insufficient. And in red, those interventions that actually caused side effects or made things worse. And you can see that by far, the interventions that improved fatigue was actually, not surprisingly, things that are non-pharmacological, things like exercise, aquatherapy, resistance yoga exercise, right? So, for example, behavioral education, fatigue management. It's interesting that when patients understand how to deal with fatigue, their fatigue improve. It's not surprising, but it's actually an intervention that is relatively simple to do. And again, MS Foundation, they do a wonderful job in enhancing education in our communities. In terms of pharmacological interventions, I was disappointed when I saw this study that showed that there was absolutely no difference between placebo and many of the drugs that we often prescribe for fatigue. Amantadine, modafinil, methylphenidate, they are pretty much all perform the same thing. Adderall and methylphenidate, they were the ones that actually improved a little bit of that daytime sleepiness, but it did not improve fatigue. And some studies are looking at, for example, vitamin D analogs, and they have a little bit better scores in terms of fatigue, and particularly in the cognitive subscale than the traditional fatigue medications that we prescribe. As mentioned before, education, exercise, aquatic therapy, psychobehavioral interventions, those are interventions that have been proven to improve fatigue. And just to end the fatigue talk here, I would like to remind us that many patients struggle to say, is that normal? Am I tired because I'm in my 50s, or because I'm tired because I have 3 kids? Well, the distinction between normal fatigue and pathological fatigue, it truly is when that blurs the line of affecting your personal, social, physical, and occupational well-being. So if fatigue is affecting your social life, your work, your performance and your house, your personal relationships, that's not normal fatigue. That's something that we need to take seriously. So in the last few minutes, I would like to wrap things up by saying, so how do we approach this? We know that it's complex. We know that there are many factors that affect quality of life in MS. We talked about fatigue at length. We talked about depression, cognition. Those are the usual ones. So how do we fix all of this in 15 minutes in the clinic? Well, as you can imagine, it's impossible. It takes a village. It takes a team. And that's why we are talking to you today, that ideally your care should be handled by a team of professionals. It's not just having a neurologist or a nurse practitioner. You need to have a care manager, you have to have a wellness coach, pharmacist, nutritionist, physical therapist, often urologist to take care of that bladder, sleep disorder specialist. Um, so many providers that actually should be looking at your problems from their angle, and hopefully we can put that picture together for you. In terms of your role is key in terms of communication, right? So it's very important when you come to our office or the clinic or you see your providers that you come prepared, you come ready to tell us your symptoms, but not only that, but also give us an idea of how often you have these symptoms. Keep a journal. There are now online journals you can do. Even your cell phones can measure your sleep levels and how many hours you sleep, can measure the number of steps you give. So all of that information that you can bring will be extremely important. Some offices offer online patient portal and you can communicate through us through that level, but also group and consultations, right? So we have many group MS groups in the areas that you can actually continue to participate and help us understand how these symptoms are impacting your life. In terms of lifestyle modifications, as I mentioned before, there are many. We know that cognitive rehabilitation, mental, social stimulation, mindfulness, of course, eliminate any toxins you have in your life, smoking cigarettes, salt, those are the usual ones that we know that has a negative effect in your overall quality of life, trans fats, sugar. So all of the things ideally you should be eliminating from your diet. Weight control, sleep hygiene, as well as vitamin D. So those are factors that we know play an important role in MS. An example of a multidisciplinary approach to patient education and empowerment is a program that is actually sponsored by MS Foundation and is organized by the Brain Health Center of the Rockies here in Fort Collins, Colorado. I was talking to Deborah before that since the pandemic, one of the consequences of that, which I guess is a positive consequence, is that we moved these programs to online and virtual formats. So that is now allowing us to offer these at no cost to any patient anywhere. So we have patients anywhere from California to New York. And this is now a 5-week program. So I have to change that flyer. We had to change it to 5 weeks because of the number of patients that we have and the requests that we get. So we want to serve as many patients as possible. The way to sign up is through that website that is listed there, www.brainhealthcr.org, and it's absolutely free of charge. And in those 5 weeks, we cover anywhere from MS 101, role of disease modifying therapies, exercise on the brain. We talk about the science of exercise on the brain. And we have PhDs from CSU, Colorado State University, that actually have an entire lab dedicated to the science of exercise. We have physical fitness, yoga. We have examples of home evaluation and maintenance therapies. We have nutritional assessment and counseling, diet. We have a week of arts in medicine where we have music therapists from CSU as well, working with our patients on using music as ways to improve balance, ambulation, speech, as well as fun social activities, right? We have a workshop on fatigue, cognitive fitness, as well as we wrap the 5 weeks into a Q&A session, and we have multiple organizations also coming and visiting with our patients.
I think we just lost your audio and you're frozen, Dr. Miravalle. Not sure if you can hear us. We might very well. Okay, Casey, can you see him?
No, I have lost Dr. Miravalle's audio as well. Let's give him a minute and hope
Yeah,
that his network catches up.
and
Um,
he may come back in. Yeah, hopefully he can get back in. Oh, let's see. Let's see. Okay. Well, maybe he's not.
I think sometimes it can take a minute or two to restart your Zoom. So
Okay.
let's
If anybody has any questions that they'd like to ask, now would be the time, since he's not here, to think of those and possibly put them down in the chat or in the Q&A area. And if by chance he's not able to get back with us, we can always send those questions to him for you and get those answered. Right, Casey?
Absolutely.
Yeah, so that might work out also. We'll wait another minute for him because I know he had a little bit more to say. Let's see. We do have something. Casey, did you get his, somebody had asked for his website and I didn't get it quick enough. It left before I was able to write it out. Did you happen to remember that?
I think I do know what it is. So give me a minute to test it and make sure.
Okay, that would be nice if we could put there. We'll try to get that up for all of you. Thank you, everybody, for saying that it was a great presentation. We love Dr. Miravalle. He's awesome. Oh, there you go. brainhealthcr.org. Thanks, Joan. Okay. We don't know if he's going to be able to come back. He might very well. He said he had some difficulty with his electric. It had left earlier. I think it was either yesterday or earlier today, and he wasn't sure that he'd even have it. So he may very well have lost his electricity again, which means no computer.
Well, if that's the case, I imagine that he will text or call us to let us know. So we ask everybody for their patience. We'll just give it another minute or two to find out what's going on with Dr. Miravalle's connection.
Let me see if I can get a hold of him.
We had a question on Facebook that I would like to address. Just one moment, please. Diana Novak says, transportation is a problem for me, so just wondering how to figure that out. I have no car. Well, you will be happy to know that the Multiple Sclerosis Foundation does have a transportation program that can assist you in getting transportation to and from your doctor's appointments or MS-related care. They can also help you to get connected with your local paratransit that can provide you service. So what I recommend that you do is get in contact with our program services department. You can call 888 MS Focus. That's 888-673-6287. Or you can email support@msfocus.org. And I will respond to your Facebook comment with those numbers and that information. Does anyone else have questions?
Yeah, this is a great time to ask questions about our organization. I did hear from Dr. Miravalle, though he did lose electricity. one of the only drawbacks to doing something like this rather than live is that we never know if we're going to be able to keep the connection. But he said he's not able to get back on and he's sending his apologies. So This is a great opportunity for Casey and I to be able to answer any of your questions if you have them about our organization. So.
All right. I see Erica had a question about the site. I assume, Erica, you are referring to the site for the brain health program that is in the chat. If you scroll up a little bit, you'll see it. It's brainhealthcr.org. And for those who wanted to know about the transportation program, you'll find more information about that at our site, which is msfocus.org.
Mm-hmm. Casey, I think if nobody has any questions for us, we might just close up a couple minutes early. If that's okay with you?
Yes, I think that we'll do that, and hopefully we'll be able to schedule Dr. Miravalle again soon so that he'll be able to answer any questions that you had or finish his presentation.
I do believe we have 2 participants that have raised their hands. So let me see who that is. Let's see, we have Erica. Why don't we, Erica, go ahead and ask your question. Erica, you're unmuted.
Oh,
Hi.
sorry, I'm typing away like 100 miles an hour. No, I got it now. It's brainhealthcr.org. I apologize. My thing isn't showing history.
Okay, good. So you got
But
your.
thank you for this. It was wonderful.
You're welcome. You're welcome. Okay, let's try. We have a Eureka, and we're going to allow you to speak.
Yes, Deborah, can you hear me?
Yes.
Okay, great. Also, wonderful program. Thank you so much. This is actually my first program. And so I'm really excited. I'm in Louisville, Kentucky, and Norton Healthcare has a great resource center. I picked up an application for home care assistance. I feel overwhelmed, and I end up paying a lot in late fees, and I have so many bills and appointments to navigate. And can you tell me more about that program and how I would actually find someone who does that kind of provides that kind of service?
Sure. So, Debbie, do you want me to take this, or did you want to?
Well, I just missed the program. Otherwise, I would be happy to answer.
Home care.
It was home care. So either one, you can speak to it or I can do it, whichever you like.
All right. Well, you know, when you're feeling overwhelmed, you have so many things that you have to deal with related to your MS. Usually the best thing I can say to you is actually go ahead and make a phone call. We don't use the phone nowadays, right? I just realized my video is off. Let me turn it on so I can talk to you face to face.
Hello.
Hello. So what I recommend is to call our toll-free support helpline, because they are going to help you figure out the programs that we have and that other agencies have that are best for what your needs are.
Okay.
So for example, if you're overwhelmed with bills because, maybe you had an exacerbation and you couldn't work, well, you might need our emergency assistance program. If you have difficulty paying for your doctors because you don't have insurance, you might need our healthcare assistance program. If you need someone in the home to help out because your MS is preventing you from doing daily tasks, well, in that case, then you might need our home care assistance program. But if you go ahead and you give them a call and you describe your situation, a caseworker is going to work with you to help you figure out what programs there are that are available for the problems that you have. But specifically to your question, the home care assistance program, what it does is provide for short-term, in-home, non-skilled assistance. So it's not nursing care, but it's
Right.
a home care aide who can come in to help with things like cleaning and housekeeping, personal care. Even there's a program that if you end up in the hospital with a relapse and you need someone to come pick you up, take you to the pharmacy to get your medications, get your refrigerator stocked. So it's in-home help, but on a short-term basis. If you need a longer-term program, they'll help you find those services.
Okay, thank you.
You're very welcome. I see Dr. Miravalle has made it back. Wonderful.
Sorry for that, and sorry everyone. We had a power outage in the area, so I was completely out of it. So, but I'm using my cell phone now, so apologize for that.
We're just thrilled to have you back.
Yes. Wow, technology. I love it.
Right,
Okay.
right.
So
Well,
here he is. If anyone has any questions, we can ask him now.
So let's just review. If you ask questions, you can either type them in the chat or the Q&A, or you can use the raise hand feature. If you are on a mobile device or a newer version of Zoom on a computer, you should see a little raise hand button on the black bar at the bottom of your screen. We'd love to hear from you. Any questions that you have about Dr. Miravalle's presentation, or questions in general.
Nope, I guess you must have answered every question they had. Dr. Miravalle, very good job.
well, thank you again, and apologize for the
No problem.
lack of electricity in the area.
I know, we never know what's going to happen. The beauty of all this technology. You know what, let's call it quits for today. And I did give everybody the option, as I said to you by text, that if they have a question they think of later, go ahead and email it to us, and then we'll send it over to you.
Sounds good, Deborah. Thank you again for the invitation, and thank you for your attention.
You're welcome. So for everybody, that's all the time we have for now. If you've missed any part of this conference, it will be replayed on msfocusradio.org and available on demand on our MS Focus SoundCloud page or our YouTube page. Remember to follow MS Focus on Facebook, Twitter, and Instagram for times and access information. Our next teleconference will be this coming Monday, June 21st at 6:30 p.m. Eastern Time. Our speaker will be Dr. Aaron Boster, MD, and he'll be talking about being 5 for 5 in your fight against MS, 5 principles to live by. I want all of you to know that as soon as each of you leave our conference today, you'll receive a short survey. We would greatly appreciate you taking a moment and filling it out. It's very short, as your answers help us determine if what we're showing you and offering you educationally is what you're interested in. It also gives us an opportunity to share your interests with us, the opportunity. So our sincere thanks to all of our attendees for your participation, and especially to Dr. Miravalle, who was kind enough to share this information with us today. Have a great day, everybody, and we hope to see you again in the near future. Thank you.